Toxic multinodular goiter. It is an enlarged nodular thyroid containing one or more autonomously functioning nodules leading to a state of hyperthyroidism. This condition is also known as Plummer disease, so named after Henry Plummer of the Mayo Clinic in 1913. Toxic multinodular goiter is the second most common cause of hyperthyroidism in the United States after Graves' disease. Among the elderly, as well as those who live in iron deficient regions, toxic multinodular goiter is the most common cause of hyperthyroidism. Toxic multinodular goiter also has a female predominance with an approximately 5:1 female-to-male ratio and typically affects adults above the age of 50 years. Autonomously functioning nodules in toxic multinodular goiter often results from mutations in the TSH receptor gene, leading to a constitutive synthesis and secretion of thyroid hormones. These warm or hot nodules are rarely malignant and typically do not require biopsy. However, these nodules can coexist with other non-functional nodules in the same gland, which should be evaluated independently. The workup of toxic multinodular goiter consists of both biochemical and radiographic testing. As with Graves' disease, thyroid function tests are mandatory in order to diagnose hyperthyroidism. In addition, a survey of thyroid antibodies, including thyroid receptor antibodies, is necessary to identify coexisting autoimmune thyroiditis and rule out Graves' disease. Nuclear scintigraphy is the first-line imaging study, and in the case of toxic multinodular goiter, can identify the location and distribution of autonomously functioning nodules and/or regions. In addition, ultrasound is highly recommended as a correlative study to assess overall thyroid size and characterize any non-functioning nodules that may require biopsy. The three management options for toxic multinodular goiter, similar to Graves' disease, are antithyroid medications, radioactive iodine, and thyroidectomy, but with some differences. First, antithyroid medication is generally not advocated as a long-term management strategy except for patients in whom the other two options are absolutely contraindicated, such as in some elderly or otherwise ill or frail patients with limited life expectancy. Because this disease state is not autoimmune in nature, autonomous nodules do not undergo remission with medical therapy. Second, the radioactive iodine with iodine-131 is the most common definitive treatment for toxic multinodular goiter in the United States. However, the dose of radiation is typically higher and by extension the risk of treatment failure and need for retreatment than in Graves' disease because of lower uptake of iodine in toxic multinodular goiter. And third, both radioactive iodine and surgery should be preceded by optimal preoperative treatment of the hyperthyroid state, which typically includes methimazole with or without beta blockers. However, supersaturated potassium iodide and Lugol solution are not indicated for toxic multinodular goiter as they are for Graves' disease, since the high iodine concentration may not achieve a temporary euthyroid state from the Volchenkov effect. They induce hyperthyroidism from the Jord base dose phenomenon. Near total or total thyroidectomy is generally recommended surgical treatment for toxic multinodular goiter. As in the case of Graves' disease, complete extirpation can be performed with a similar low rate of complications as subtotal thyroidectomy, while at the same time virtually eliminating the risk of disease recurrence.